All right, class. Today we're talking about one of the most important things you'll do as a nurse, assessing pain. Pain is deeply personal. It's subjective. Two people can have the same injury and describe their pain completely differently. And that's why the patient's own report is always our gold standard. There's no lab test, no imaging study, and no machine that can measure pain better than the person experiencing it. The American Pain Society reminds us that the self-report is the most reliable measure of pain, and the Joint Commission backs that up. Our role is to listen, believe, and act. Sometimes that can feel tricky. A patient might look comfortable or calm, but still report severe pain. You might wonder, are they exaggerating? But pain can't be proven or disproven. Everyone experiences it differently, and professionalism means setting aside personal opinions. If you ever catch yourself doubting, stop and ask, why is it hard to believe this person hurts? Then remind yourself that our role isn't to judge whether pain exists, it's to respond when it does. Now, let's walk through how to perform a complete and accurate pain assessment. A comprehensive assessment starts at admission, with every new report of pain, and whenever the patient's condition or treatment changes. It's the foundation for building an effective pain management plan. We start with location. Ask the patient to point to where it hurts or mark it on a body diagram. This helps us see if the pain is localized, radiating, or widespread. Next is intensity, how strong the pain feels. We use validated pain scales to measure this. The most common are the Numeric rating scale, the Wong Faces scale, the Faces Pain Scale Revised, the Verbal Descriptor scale, and the Visual Analogue scale. The Numeric rating scale runs from 0 to 10, with 0 meaning no pain and 10 meaning the worst pain imaginable. The Wong Faces scale uses cartoon faces with numbers, often 0, 2, 4, 6, 8, and 10. It's helpful for adults and children as young as 3. Just remember, we never match the patient's facial expression to the picture. The patient chooses the face that best describes how they feel. The Faces Pain Scale Revised is similar, but has been shown to work better with older adults and culturally diverse patients. The Verbal Descriptor scale uses words like mild, moderate, severe, and worst possible pain. And finally, the Visual Analogue scale, the 10-centimeter line where the patient marks their pain level, is mostly used in research, not everyday nursing practice. Next, ask about the quality of the pain. Is it sharp, dull, burning, throbbing, or shooting? These words help identify whether pain is nociceptive or neuropathic. Ask about onset and duration. When did it start, and is it constant or intermittent? Then discuss aggravating and relieving factors. What makes it worse and what helps? Finally, explore how pain affects the patient's daily life. Ask, what can you no longer do because of pain? Or, how does pain interfere with your sleep, mood, or mobility? Understanding this helps you plan care that's both effective and realistic. When pain is acute, your focus is recovery. You might say, good pain control will help you move, breathe, and recover faster. When pain is chronic, it's about function and quality of life, helping patients manage their symptoms so they can still live meaningfully. This brings us to what's called the comfort function goal. Every patient should have one. Ask, what level of pain would allow you to move, rest, or function comfortably? A post-op patient might say, if my pain stays around a 3 or 4, I can walk. A chronic pain patient might say, if I can keep it under a 5, I can get through my day. That number becomes your benchmark for success. Now, you can't get accurate assessments unless the patient understands how to use the pain scale. That's why patient education is a big part of this process. Start by showing the scale and explaining its purpose. You might say, this scale helps us understand your pain and set goals for relief. Anytime you're hurting, let us know. We can't always tell by looking. Then walk them through the numbers. 0 means no pain. 10 means the worst pain possible. Around 5 would be moderate. Explain that pain doesn't have to be unbearable to count. It can be aching, burning, tight, or just uncomfortable. Ask for examples to check their understanding. Can you give me 2 kinds of pain you felt recently? Have them practice rating their pain, either with their current discomfort or one of the examples they mentioned. Then, together, set that comfort function goal. If the patient is in too much pain to learn, don't wait. Treat the pain first, then teach once they're more comfortable. Now, Not every patient can self-report pain. Some are too ill, sedated, or cognitively impaired. These are our most vulnerable patients, and this is where we use the hierarchy of pain measures. Here's how it works. First, always try for self-report, even in patients with dementia or limited communication. Use large print or vertical scales, simple words like ache or hurt, and allow plenty of time. Sometimes nodding, blinking, or pointing to numbers can substitute for speech. If self-report isn't possible, the second step is to consider the condition or procedure. If the situation is obviously painful, for example, post-op trauma or mechanical ventilation, assume pain is present and document it according to policy. Third, observe behavior. Look for facial expressions, restlessness, moaning, or withdrawal. Each patient has a unique pain signature, a set of behaviors that indicate distress. Family members and caregivers often recognize these best. Fourth, evaluate physiologic indicators like heart rate or blood pressure. But remember, these are the least reliable. People adapt, and vital signs can appear normal even in severe pain. And fifth, conduct an analgesic trial. If pain is suspected, administer a small dose of medication and observe the response. If behavior or comfort improves, you've confirmed pain and established a starting point for treatment. We also have specific tools for patients who cannot self-report. The FLAC scale is used for infants and young children. It looks at facial expression, leg movement, activity, crying, and consolability. Each is scored from 0 to 2 for a total between 0 and 10. Scores of 0 mean relaxed and comfortable. Scores of 1 to 3 indicate mild discomfort. 4 to 6 is moderate pain, and 7 to 10 represents severe pain. For adults with advanced dementia, we use the Pain scale, the Pain Assessment and Advanced Dementia, developed by the Department of Veterans Affairs. It's modeled after the FLAC and helps identify pain through observation. And in the ICU, for patients who are intubated or sedated, we use the CPOT, or Critical Care Pain Observation Tool. It's also patterned after the FLAC, but tailored for critical care. One important reminder, the absence of behavior doesn't mean the absence of pain. Some patients are too weak, paralyzed, or sedated to move or speak, but that doesn't mean they're comfortable. Always consider the full picture. After treatment begins, your work isn't done. Pain must be reassessed regularly. You want to know if the plan is working and if adjustments are needed. At a minimum, reassess whenever the patient reports pain, before and after analgesic administration, and as the situation changes. Timing depends on the route. Reassess about 15 to 30 minutes after IV or IM medication and 1 to 2 hours after oral medication. In unstable situations, like IV titration in the PACU, reassess every 10 minutes if needed. For stable patients, an hour after oral meds is usually sufficient. And don't forget our veterans. Research shows that chronic pain conditions like arthritis, fibromyalgia, headaches, and back pain are much more common in veterans than in the general population. Pain levels tend to be highest in younger male veterans, especially those who served in Iraq and Afghanistan. Always ask patients if they've served in the military. It helps you understand their experience and anticipate their needs. Veterans often benefit from multimodal and multidisciplinary approaches: physical therapy, counseling, mindfulness, or even yoga. Studies show yoga can help veterans reduce pain and disability while lowering opioid use. As nurses, we advocate for care that's both compassionate and evidence-based. We recognize that pain is shaped by more than just physiology. It's affected by trauma, experience, and identity. So here's what I want you to remember. Pain is subjective, and the patient's report is your foundation. A thorough assessment includes location, intensity, quality, onset, aggravating factors, and how it impacts daily life. Teach patients how to use the scale and always set comfort function goals. For patients who can't self-report, use the hierarchy of pain measures and validated tools like FLAC, Pain and CPOT. Reassess regularly before and after every intervention, and always consider unique populations, especially our veterans. Pain assessment isn't just documentation, it's advocacy. When we assess well, we treat well. And when we treat well, patients heal faster and trust grows stronger. That's the heart of nursing.